All right. So I want to thank you all for coming. And I know that we have an audience that consists of researchers and scholars and people that are doing public health work, community people from, it's a mix. So what I want to do is talk to everyone here. And I want to say something to everyone. But I want to take you through a couple of things. I have a couple of specific messages for the researchers. You know who you are. And I have, and mostly to the researchers, but mostly to the researchers about community-based research, what we are doing wrong and what we might want to do better. But I think I have a message for everyone. So I want to take you through kind of my journey to try to understand this issue of why health disparities exist and where it's taken me over these years. Are you not able to hear me? Oh, I thought I was, okay. I'm going to try the technology. Let me try this one. Now, they gave me the lavalier microphone. I'm going to see if this works. Got to turn it on. How's that? Is this better? Oh, a little too good. Okay. That's good? Yeah. Okay. You mind if I don't stand behind this thing? I really don't like that. I feel like it separates me from the audience. So what we're going to do is talk about, I'm going to talk about four things. I want to talk a little bit about myths about health disparities. In other words, what is not the reason that we have health disparities, but many people believe it is. So you want to try to dispel some of those myths. I want to talk about a message to the researchers, and then I want to move on to what I believe causes the health disparities, and then a message about community-based research. So can you imagine this society without health disparities? Can you imagine that? What would it take for us to get there? What would need to change? It's hard to do now, right? Now that we know how big of a problem it is that we have in this country. But I can imagine this society without health disparities, because there was a time that I didn't know that there were health disparities. Now, this was back when I was in graduate school. I was working on a PhD in in political sociology. And I was trying to understand what was the impact of Black political empowerment on quality of life for Black communities. Back in the 1960s and 70s, you started getting more Black politicians elected to offices. People like Ed Towns, Major Owens. We started getting these people. I wanted to know, had they made a difference? Had it mattered to the Black community? Was the quality of life better? And as I started doing research on how do you measure quality of life, I kept coming up with these health messages. I kept coming up with these statistics about health, which interested me, but I knew nothing about it because I thought, like most people, that health was about biology and only about biology. It's much more complicated than that. So one day when I was writing my dissertation, and if you've written a dissertation, you can relate to this, when you get to that moment where you are just so isolated and bored, and it's so tedious that you just need to do something else, right? Anybody feeling me? Right. So I was there, it was that day. So I decided to take a walk. So I'm walking around the college town in Ann Arbor, Michigan. So if you've been there, you know that downtown Ann Arbor, Michigan, where I was walking, was not a long walk, right? It was a pretty small place. So I get to this used bookstore. I walk in the bookstore, and I head straight over to the used books, the clearance section, right? So I'm in the clearance section of the used bookstore, which is about all I could afford. And I come across this book. I start looking through this book, right? Now, the book is this. Still sits on the shelf. This thing's not working. Can I get a little help with the technology? Maybe the downward arrow. Now I'm pushing all the buttons. Maybe I got to stand back here. All right. All right, I'll just stand here, all right. So the book was called The Night to Remember. This is a book about the Titanic, right? And it probably tells you something more about my state of mind that day, but I'm interested in the book about the Titanic, right? So I start thumbing through this book, and I'm looking for, I'm just looking for something to read, something that does not have a bibliography, right? So just as long as it's not like an academic school thing. And I come to this page where they start talking about survivors on the Titanic. Now you gotta remember, this was before that movie came out, right? So I didn't know that people survived the Titanic. I thought the story was simple. They hit an iceberg, they sunk, people died, that's the story, right? But instead, they started talking about who survived, and they talked about who survived based on the class of ticket that they had. And I start going through this data, and I start calculating the survival rates, which tells you something more about my state of mind, right, at that moment. Clearly, something wasn't clicking right. But here are the rates that I calculated. It's not moving. I did. Well, how about okay. I was literally just going without the slides, but okay, so this thing working now? Yeah, this is working. Okay, so I don't have to stand back there. All right, I'm sorry, this keeps messing up my flow. Everything's messing up my flow. So these are, I'm gonna roll with it. So these are the statistics, right? It showed that the class of ticket determined was one of the biggest determinants of who survived the Titanic. Now, how can this be? Because all three cabins went down, right? Third class, first class, second class, everybody sunk. Now, we now know how this happened, right? Because we've all seen the movie, but at the time, I hadn't seen this movie yet. But what was fascinating about it is that it was really a story about resources. Who got access to what? Because there was only enough life raft space on the boat to accommodate 53% of the people on board. So that means that on the evening of April 15th in 1911, at 11:40 p.m. in the North Atlantic, space on a life raft was a scarce resource. And when it comes to scarce resources, who you are determines who gets access to what. Now, this seems to me a really nice analogy to the US healthcare system. Big, expensive ship, giving out unequal treatment, destined to hit an iceberg and sink. And when that happens, I think the results are going to look something like this. Who you are will determine how far you will fall. Now, you might say this was 1911, that was more than 100 years ago. This could never happen today, right? Right? Look, I know we're not in church, but see now, I call and you, so you do know what to do, you're just not doing it, right? This could never happen today, right? Could it? Well, this is the US airliner that landed on the Hudson River a few years ago. I'm sure you all remember this. And I did not Photoshop this picture except to write in first class and coach class. Now, how is this picture possible? It's possible because, from a government standpoint, Congress could have passed a law that said you cannot operate an airline in the United States without enough lifeboat space for everybody, but they didn't. But you didn't need Congress. The Department of Education did not need a law to pass a policy that simply said you can't operate an airliner in the United States without enough lifeboat space for everybody. But you didn't even need government, because US Air could have simply said, we will not purchase an airliner that doesn't have enough lifeboat space for everybody on board. And you didn't even need US Air, because the manufacturer could have simply said, as a matter of policy, we will not make an airliner that does not have enough lifeboat space for everyone on board. So health policy happens at many different places, not only in government, but it also happens in the corporate boardroom, which is where most policies that affect our communities occur. So if we want to be effective policy actors, we need to understand where the policy is made. There is no government policy that determines which community will be a food desert. It is corporate policy that determines which community will be a food desert. So to be effective in policy means more than simply going to the city council and arguing for a law, but it means understanding where and how policy is being made, including in the courthouse, in the courts, and being an actor in all of those venues. Okay, enough health policy preaching. Let me move on. So most people learned about this topic of health disparities when this book was published. This is Unequal Treatment. This is a report that the Institute of Medicine published in 2002. This wasn't the first report on this topic, and in fact, it wasn't even the first report that the Institute of Medicine published on this topic. But this report has had a bigger impact than anything in the past. And the reason that this report has been so impactful, I believe, is because they did something really clever. Now, in the past, they would put out these reports where they would show these health statistics, chart after chart after chart, showing that this group is doing worse than that group, and this group is doing worse than that group. And people would look at these reports and they would say, well, that's a big problem. That's a societal problem. That's a healthcare access problem. That's an economic problem. That's people, individuals that don't use healthcare when they have access to it. How do you fix that, right? But this report was really clever. What they did was they said, we're going to take all of those arguments off the table. And what Unequal Treatment is a report of good, high-quality studies on patients that had health insurance, that showed up in the healthcare system to try to get care. So there's nothing about healthcare access in this report. There's nothing about not having insurance in this report. There's nothing about patients not wanting to get care, because everyone in this report tried to get health care. And then they said, among people that have access to health care, are there disparities in the quality of care that they receive? And this is why this report has been on the front, put health policy problem on the front burner. But when we talk about what is health disparities, I like this chart as a nice summary of the problem. Health disparities can be summed up pretty nicely with this chart. Now this is for what, 2009? I stopped updating this chart in 2009 because it's the same chart. If it was 2009, if it was 1999, if it was 1980, 70, 69, it's the same pattern. That the disparities exist, that they seem to be intractable, that the relationships between one race group and the next is about the same, and we've made very little progress at eliminating the gap, although the overall rates are declining, right? And I believe that the reason that we're making little progress in eliminating those gaps, the reason I believe that much of what we are doing about health disparities is going to fail is because we haven't yet stopped to really take account of the diagnosis. Everyone is operating from some underlying concept of what they think is the cause, but they don't necessarily explicitly talk about what they think the cause is. So we throw resources at the problem without first diagnosing the problem. It would be as if a doctor walked into the waiting room and just started handing out pills, right? Now there's a chance that you might give the right pill to the right person, but your odds of you getting the pill combination and the pill disease combination right is much better if you first stop, take account, and make a diagnosis. So when I talk to most people about this topic of health disparities, and they start talking about their own diagnosis, and usually it comes down to these three things. Health disparities are about biological or genetic differences between race groups, or it's not really race, it's really social class, it's really poverty, it's really income, which I'd always say, well, why would that be any better? Even if that was true, why would disparities based on income be any more acceptable? Or they say that, it's really a healthcare problem. We just need to get better access to healthcare, and once we do that, health disparities goes away. Right? So let me kind of talk about each of these, what I call myths about why disparities exist and why neither of these are true. First, the healthcare access problem. So this is a chart from a study that I led a few years ago where we looked at this procedure. called cardiac catheterization. And what this is, basically, it's a procedure that's used to diagnose heart disease. Right? And this was from 3 hospitals, all in Baltimore, and we took 10,000 patient records. We analyzed those records to determine, based on the medical makeup of these patients, were they appropriate candidates? Should they have been given a referral to get this procedure, which can be life-saving because it would lead to an understanding of whether or not they needed heart bypass surgery, right? Every patient in this study was a candidate, medically was a candidate to get the procedure, 100% of them. Every patient in this study had health insurance that would have paid if they had got a referral to get the procedure done. And every patient in this study was at a hospital that had a cath lab. In other words, that had the ability to provide the service. But we see 2 things in this chart. We see an overall quality problem because even the white patients are only at about 80% when they should have been at 100%. But we have a disparity in quality problem because the black patients were less than 60% when they should have been at 100%. Another study that I like a lot, this comes from the VA hospital in Pittsburgh, and this is looking at who gets access to heart bypass surgery. Now, what I like about this study is that all of these patients are VA patients, so they're all on the same insurance, they're all VA patients, that the physicians are on salary, right? So there's no financial incentive to either do the procedure or not, and they all should have received a referral for bypass surgery. But you find that only about 50% of white patients receive it, which means we have an overall quality problem, but less than 25% of black patients receive it. So simply improving access to care, which the Affordable Care Act apparently is doing and will do, it is necessary, it needs to happen, but in and of itself, it will not eliminate this health disparities problem. Now I'm going to move on to the next one of this biology thing. So is anyone here not familiar with this drug? Anybody? We talked about this earlier, right? I call and you? All right, so you know what to do. All right, anyone not know about this drug? All right, well, I'll tell the story. I didn't know if I had to tell the story or not, because I know we have a lot of physicians here. Okay, so BiDil is a drug used to treat congestive heart failure, which is a very terrible disease. It affects about 500,000 new cases in this country every year. And prognosis is about 5 years of life once you're diagnosed, right? So very expensive disease. You wind up using a lot of emergency room care. And back in the 1970s, these new drugs started coming out, drugs that today are common drugs that we use for hypertension and heart disease, like for the clinicians in the room, calcium channel blockers, beta blockers, those types of drugs, right? And these physicians found that if you took these new drugs and you added these 2 very inexpensive generic drugs that I have listed here, that they were getting great outcome, that patients were doing well, really well, if you put that combination together. And then so they said, you know what, let's do a study and let's see if we can prove that this really is the case. So they do this study, and the study shows that this combination of drugs is really helping a lot of people. So they published the article in the New England Journal of Medicine, and this is a really important thing, right? Because we now have a new therapy that's going to help a lot of people. And that would have been great if the story ended there. But it didn't end there. They then got the idea that what if we took these 2 really inexpensive drugs and we put them together in one pill, and then we got a patent on this new combined drug, then we can make a lot of money. So they do that, and they get the patent, and then they're ready to come to market with it so they can make their fortune. But the FDA says, no, you can't go to market with this drug. And the reason you can't go to market with this drug is because that study you did in the New England Journal of Medicine was fine, but it wasn't done to the exact standards of FDA. So you have to do a new study. Now, the problem with doing a new study is that if you do a new study, by the time you finish that study, you would no longer have the monopoly on the drug. and then the drug would become public, and then it would become cheap, and then everyone would be able to make it, and you wouldn't make your money. So what do? They go back to the old data from that first study, and what they find is that the drug is more effective in Black patients. Now, I said it that way very intentionally, more effective in Black patients. Have you heard that terminology before? I know the health professionals have heard that kind of talk. This is more effective in Black patients. Okay, so now I gotta say a couple of words to my health professional researcher brethren and sistering, okay? When we say that a drug is more effective in Black patients, this is what we're actually saying. If you have a group of white patients and Black patients with the same drug, and let's say 75% of the Black patients benefit from the drug, and 65% of the white patients benefit from the drug, that 10 percentage point difference, we would say, is statistically significant, right? And because it's statistically significant, we would say it's more effective in Black patients. But is that accurate? Is it really more effective in Black patients? Or was it effective in more Black patients? Right? So if you were part of the 75% of Blacks that benefited, you benefited. If you were part of the 65% of whites that benefited, you benefited, right? It didn't matter. You didn't benefit more. A larger percentage of Black patients benefited would be an accurate statement. But so they go back to that data and they find an outcome like that and they say the drug is more effective in Blacks. We have a drug that will help deal with the health disparities problem. And then, and I'm going to call some people out, and then they go to the NAACP and they go to the Congressional Black Caucus and they say, and the Association of Black Cardiologists, and they say, we have a drug that's more effective in Black patients. You need to help advocate for us to get a new patent. This one is only for use of this drug in Black patients. And what do you think happened? They got the patent. So now we have a new drug that is for use in only one race group, even though everything we know about the drug tells us that it's effective in all race groups, right? But now they have time to do a new clinical trial. So they do a new clinical trial. But this clinical trial is only done among Black patients. And what do you think that clinical trial found? I'll give you one guess. That BiDil is effective. Now, why did that study find BiDil is effective? Because BiDil is effective, right? If it had been Black patients or Eskimo patients or East Indian patients, it would have been effective because everything we know about this drug is that it's an effective drug. So now in 2005, not 1905, 2005, we get the first drug ever made available only for one race group. So my question is, and this one is to the clinicians in the room, you're sitting in your treatment room, and a patient walks in, Dr. Ford, patient walks in, and you think this patient might benefit from BiDil. Do you prescribe it? Who do you prescribe BiDil to? Do you prescribe BiDil to this African-American gentleman who has 2 grandparents from Scotland, 2 grandparents from Jamaica, and was born in the Bronx? Do you prescribe BiDil to this African-American gentleman? 2 grandparents from Kenya, 2 white Americans? Do you prescribe it to this African-American gentleman? Now this guy's got 1 grandparent from China, 1 from Thailand who also has Chinese ancestry, 1 white American grandparent that has Native American ancestry, and 1 Black American grandparent who has white and Native American ancestry. From whom did he inherit his BiDil receptor? Right? And how do you know? And how do you know? Right? By the way, do you offer it to this gentleman? Looks like a Black eye to me. Right? But of course, this is golfer Vijay Singh, who is from Fiji, and he's not an African American at all. And I hope one day that he will never need BiDil, But if he ever did, I would hope that would be made available to him. So this is the insanity that 2 years after the Human Genome Project proves that there are no genetic differences in race groups, we get a drug approved for use in only one race group. So the way that this insanity creeps into our brains is in very subtle ways. We see the difference in skin color, and we assume that what's happening outside the skin tells us everything that we need to know about what's happening under the skin. Now, if you sit any scientist, any physician, any nurse down and ask them that question, they would say, of course, that's ridiculous. But it's subtle, and it seeps into our thinking in little subtle ways, that there are ways that your race matters biologically. The last myth is that health disparities is not really about race, they're really about income. And this one is the easiest one to dispel, so I'll just do this one really fast. Here's a couple of charts that I put together. This is from the National Health Interview Survey, so this is like the official health data set for the country, right? This is the most official of official statistics. And I just put together these charts looking at race differences and different outcomes, different health outcomes within different education levels. And it shows you it really doesn't matter what outcome you use, the pattern is the same. This one here for infant mortality, I just want to point this one out here, that black women with a college degree have a higher infant mortality rate than white women with less than a high school education. So now education matters, right? So the higher your economic status, the better you are. But race matters also. Both matter. Now, I do want to make a brief message, and for the non-researchers, please just bear with me for a moment. I have to say this to the researchers in the room, because I know there's at least one or two of you that when I was showing those charts, you said that, well, that's not a problem because we deal with that problem with something that we call multivariate modeling. All right? Researchers know what I'm talking about, right? So I want to do this quick demonstration. Please, just bear with me, the non-researchers. Believe me, this won't be too boring, but it's important to make this point to the research people. I'm going to do a little demonstration here about multivariate modeling and race disparities research. And what I'm going to do is I'm going to do a very simple analysis using the health interview survey, where I'm going to look at whether or not we can do a simple study of race differences in disability as measured by ADL, right? Controlling for income levels, okay? I'm going to go through the way that we're taught to do this. So in Statistics 101, we would be taught to first look at the relationship between race and having an ADL limitation. Am I right? Can somebody verify that I have passed Biostat 101, right? And this would tell us that to the non-researchers, because I want you all to pay attention to this too, because when they start talking this stuff, you need to also be able to consume this research knowledge and language, right? That 1.46 number means that African Americans have 46% greater odds of having an ADL, which is a disability limitation, compared to whites, right? And that's what you would expect. The next thing that we're taught to do is look at income. So we look at income levels of less than 20,000, 20 to 75, and 75 and above. And the odds ratio is getting lower and is significant. So how do we interpret this, researchers? As income increases, the odds of having a disability decreases, right? So far everything is right, and I'm passing 101, right? Now, 102. We put race and we put income together, and what do we find? We find that as income increases, disability, the odds of having disability decreases, and that the race effect is not significant, right? So we would conclude that it's not race, it's really income that's driving disability. And then we would publish the article, and then we would get a raise and a promotion, right? And everything would be right with the world, right? Except that we have just now added false information to the scientific literature. And people that are not researchers now will believe something that is actually not true. Because if we just went to this next step, which we never do, because we don't take 103, take class 103, you would learn that among the lowest income group, that there is a significant difference. And we would also learn this, that in the highest income group, that this rate of disability is being calculated on the basis of only 8 people. In other words, in the National Health Interview Survey, the largest data set that we have, there are only 8 African Americans with income over $75,000 that have an ADL limitation. So do you feel confident calculating a national rate with just 8 cases? All right, now here's where it really gets scary. How many studies have you seen with smaller data sets and more complicated analysis than that? Now, don't get too depressed, because just calm down, because some of the same sins that I'm talking about here today as a researcher, I have committed before I reached enlightenment. So if you search my name, you will find that I did some of the same things, that I took the same classes you took. So the point is not he who is without sin cast the first stone. The point is to repent, go forward, and don't put false information out about race disparities. So much of what we think we know about race disparities, we don't actually know, because the studies that we do are flawed. And they're flawed because the traditional research designs that we use are not appropriate to study some of the most pressing questions that face us in trying to understand health disparities. Health disparities research is not for the lazy. Here's another one. Now, the non-researchers can pay attention again, right? This is a picture that I took of a high school in the Baltimore area. I'm at the entrance of this school, and you can't really see the buildings, but you see trees and the lawn. And as I drive onto the campus, we see more trees in some of the buildings where the classes are held. I come around to the side of the building, and here's the gymnasium where the basketball team practices in this high school. Here's another high school. This one is an upper middle class suburb of Baltimore. I'm at the entrance of the campus again. You can see there's some trees in the lawn, but the building is visible to the street. I drive around to the back. Here's the soccer team going on for its afternoon practice on the open field with no bleachers for the spectators to watch the baseball game. And then when I come around to the back of the building, here are the portable classrooms, because in this upper middle class suburb in Baltimore, the high school is not large enough to accommodate all the students. And finally, here is a high school in the Baltimore metropolitan area. There's no lawn. There's some weeds here and a curve. And there's a tree. And so what's my point? The point, my researcher friends, is that the graduates of each of these institutions are coded in your data set as high school graduate. But do you think that maybe there are differences in the life chances and opportunities of these graduates? Do you think maybe there are some differences in the racial distribution of the students of these schools? So when you do your fancy schmancy multivariate model, and we put education in there, thinking that we have now accounted for differences in these populations, I want you to think of this chart the next time you do that, and whether or not the work that you're doing is really subtle enough to truly understand what health disparity is all about. I can feel the energy getting low now. You all are getting depressed. Again, I've done it too. It's okay. It's just what you do going forward. Repent. So these are some pictures of my adopted home of Baltimore. These are corner stores. I'm sure everyone here in Brooklyn recognizes these stores because they're all over here in Brooklyn and really in all major cities in the Northeast. They sell pretty much malt liquor, lottery tickets, cigarettes, some food. They're an important part of the food ecosystem in some of these communities. And in some of these communities, they're really the only source. This one happens to be just a few blocks from my office. This is my favorite one here. I love the sign because of the truth in advertising. In case you think I photoshopped this, North Avenue and Greenmont, L&M Liquors, they sell beer, wine, and medicine. Now, I really respect the truth in advertising because the medicine that they sell, of course, is the elixir for the ills of poverty. Malt liquor. This is part of my collection of malt liquor that I have in my office. In fact, I picked these up as I travel. In fact, this one I got from Brooklyn. Got this on Utica Avenue. Yeah. This is Baltimore. And of course, this is the 64-ounce bottle of malt liquor of Old Gold, Old English. 64-ounce bottle of glass, engineered for easy one-hand consumption. It's a beautiful thing. It's genius. It's evil genius, but it's genius. It's a beautiful thing. Right? So we did a study to look at where these stores were located in Baltimore again. We got all the liquor licenses. We determined which census tract they were in, and then we said, okay, where are they located? And what we found is that these stores are located almost exclusively in low-income African-American communities, not in the higher-income communities, not in the racially integrated communities, but in the low-income, predominantly black communities. So what I'm getting at is that we live in this country together, but we experience this country very differently. And when we look at these national statistics, like I showed you in the beginning, and we see the disparities, and we see the difference, and we can't figure out, how do we get this difference to go away? How do we tease this out? And then we're left with the idea that it must be biology, right? Because we've accounted for education. Well, we see how good that is. We've accounted for income. Well, we've seen the problems with that. It must be biology. It's the only thing left. Well, not long ago, well, I guess it was about 15 or so years ago now, I was asked to review an article for a journal. And this article was titled something like Race Differences in Firearm Use Among Black and White Adolescent Males. You've seen those titles, right? Something like that, right? So, unfortunately, so before I go forward, let me say, I'm going to tell this story, but it was a blind review, so I don't know who the author was. So if you are the author, you're not going to want to claim this one, so just stay quiet. Don't out yourself, and we don't have a problem, right? Because I don't know who you are, and I'm sorry to insult you, but, just don't say nothing, right? We'll move on. So they're doing this study of firearm use. Some of your faces got real serious when I said that. Violence researchers in the room. Huh? They're doing this study of use of guns, right, among adolescents, black and white adolescents. It's supposed to be a race difference study. They send it to this guy, me, to review it, who lives in Maryland. And unfortunately for them, this study was done in Maryland. So they start talking about the different locations of where they did the study. But I know all these places because I know these communities that they're listing, and I'm saying, oh, okay. And what I started noticing is that all the black males in the study come from East Baltimore. The white males in the study come from Allegheny and Garrett County. Now, Allegheny and Garrett County are rural counties in the west of Maryland in the Appalachian Mountain area. Okay. The white males are shooting long guns or rifles. The black males are shooting handguns. The white males are shooting at wildebeest or bears or whatever you shoot at in Garrett County. And the black males are shooting at, right? Now, maybe this is the study of urban versus rural. Maybe it's that, Maybe it's a study of one kind of hunting culture versus another type of hunting culture. Maybe it's that. But there's no way that this is a study of race differences, right? So if you want to study race, you need to get black males from Garrett County, of which there are some, because I personally saw them with my own eyes, and white males from Baltimore, from East Baltimore, of which there are some, because I personally have seen them with my own eyes. And then maybe you can say something about race differences, right? Maybe not then either, but at least you had a shot now. Now that's an extreme example, but I'm going to tell you one other study, and this one is more subtle example, and this is how the problem occurs. I'm going to be careful here because I don't want to out this person, because this is I'm convinced that this person is truly trying to do a good job, right? But this is one of my colleagues over in the medical school. He's doing this study on this particular disease, right? And how patient outcomes. And he asked, and it's a race disparity study, black and white patients. So he asked, would I review the article for him before he submits it to the journal? So I read it for him. I go back to him, I say, you know, you have a real problem here in your study. I don't know what you're going to do. So what's the problem? The problem is that all the white patients came into the hospital from the outpatient center, ambulatory care. They were referred in by a physician outside. The black patients are coming through the emergency room. So you would expect that a patient coming through the emergency room is likely to have worse outcomes. First of all, you're coming through the emergency room, you're in a more severe disease, right? You're in crisis, as opposed to somebody who's being referred in from an outside physician. Also, we know there's more likely if you come to the emergency department that there won't be continuity. So who do you get handed off to? Who takes over your case, and how is that managed? All of that is more complicated. So we know that patients that come from emergency departments are in worse shape and are more likely to have difficult outcomes than patients that come through the outpatient center. But all your black patients came through the emergency department. I said, you can't call this a race disparity study, really. It's really outpatient versus emergency room, and you need to really, do something about this. And he thanked me, and the article is published, as was. Now, this is a lot more subtle. And these types of things happen, and they are in the literature, and they're published, and we read those articles, and we think that they teach us something that's important and useful. And we come to the conclusion that, black patients don't do as well with this or that, because the study showed that. Or maybe it was black patients are more likely to come through the emergency department, and therefore they're not doing as well. But if we don't have the sophistication to understand that, and if we're not diligent enough when we do these studies to really understand what we are saying, and whether or not we have really designed a study that truly creates that comparison, that allows you to say this is about race as opposed to something else, then we have this situation where we're putting out this false information, or this information that may be false, because we don't even know if it's false, right? This information that may not be accurate that we put out there, and people rely on it. And this is what we suffer from. So if we really do want to deal with the fact that this country is dramatically racially segregated, and we are experiencing the country in such different ways, we need to find ways of designing studies that allow us to create true apples to apples comparisons. We need to find communities where people are living together, where people are under the same conditions, where people have the same challenges and also have the same resources that they can access, and determine, do you still find these disparities? So we went around and identified 425 communities in this country that were racially integrated, and where the black and white residents of those communities had similar levels of income and education. And we went into those communities and we replicated national studies like the National Health Interview Survey, and we wanted to know, do you still find the same disparities when people are living under similar conditions? I want to tell you what we found in that study, and then tell you how we conducted that study and how the community helped make that study possible. So first, a little bit about this. This was a community in Southwest Baltimore. It was 44% white, 51% black. It was a low-income community. Median income was only $25,000, but there was no race difference. Poverty rates were very high, but again, no race difference in poverty rates, or levels of income, or the distribution of gender. And what we did was we went into the communities, and I'll describe how we did the study after I finish giving you these results. But we successfully interviewed 42% of the adults living in that community, which is a very high response rate given that we only had 12 weeks to do this study. So what we do is we take the data from the national study and we do the analysis, and then we do the same analysis in our racially integrated community, and we want to know, do you still find the same disparities? If you don't, then social determinants, or the social environment that people are living in, may be the reason the disparities don't exist. So, those two of our interviewers. In red, we have the census data. In blue, we have our study, what we found. And as you can see, we did a fairly good job of representing the community by distribution of race, by income levels, by education levels, and also by gender. So this is the first one. This is a study of hypertension. Well, we wanted to know, do we find the same hypertension rates? And for the researchers in the room, I'm plotting the odds ratio. The way you interpret this is you say that compared to whites, in this national study, African Americans have 201% of the rate of whites. So in other words, they have double the likelihood that African American has hypertension, right? And that's what we teach everybody. That's what we teach in medical school, and that's what we all believe to be the case. But we found in our community, when people are living together in the same community, under the same challenges, that in fact, that rate was only 42% higher. When you look at obesity, this is obesity among women, 87% greater odds for a black woman to be obese compared to a white woman. In our study, it's only 25%, and it is not a significant difference. So we find no significant race difference among obesity among women when they're living in the same environment with the same conditions. When you look at diabetes rates, again, the national data tells us 61% greater odds for African American to be diabetic. When black and white people are living in the same challenging conditions, the same challenging social environment, we find no significant race difference in rates of diabetes. So, and for the aficionados in the room, here are the statistics, which I'm not going to leave up too long for you, but you can get the studies if you want to see that. So, what are we saying? What we're saying is that when you look at these national statistics, and you don't account for the fact that we live in very different risk environments, that we live in communities that place us at greater health risk because of what's in those neighborhoods, and we have less access to things that help us to live healthy lives, that's not reflected in these national statistics. And then we see race differences that are largely being caused by the social environment, the social conditions that people live in, the economic conditions that people live in. And then we say it's race. And since we can't find another reason or another way to explain it away, we assume that their race difference must be biological. When in reality, if you put white people in the same social conditions, you find the same health outcomes. Now let me say a little bit about this neighborhood. This neighborhood is about 3 square miles. In many ways, it reminded me of Brownsville, which is 2 square miles. Brownsville, by the way, is 54,000 people living in 2 square miles. That is I calculated that at being, less than a square foot per person, living up on top of each other. I lived on the 12th floor, and there were still 4 more floors above me, right? That's a whole nother story. This reminded me of that neighborhood, right? There was no supermarket in that neighborhood. This is not about McDonald's. There was no fast food restaurant in that neighborhood, none. There were no chain stores. There are no chain stores at all. There's no bank. There's no physician practicing there. There's no dentist there. There's no pharmacy there. What you have is mom and pop fish fries, corner stores, check cashing places, right? So it's a very challenging environment to live. Now, how was it that we were able to get that rate of, so the reason that the disparities don't exist in that community, it's not because the rates for African Americans are doing better. It's because the whites that live there are just as sick as the black people that live there. And this neighborhood is more common for African Americans to live in neighborhoods like this. So what we're seeing reflected in those national statistics is the fact that African Americans disproportionately live in communities that make people sick. Doesn't matter what your race is, if you live in Southwest Baltimore, you are not going to be well. I remember when we first got the data I looked at that and I saw the smoking rates. It's 3 times the national rates. And that's when it really occurred to me how often I'd be walking down the street and people would ask me for a cigarette. And after a time, it didn't even register anymore, that people were constantly asking me for cigarettes. It was so common that I didn't even think about it. And by the way, talking about working with communities, we came back after we did this study. We had a town hall meeting where we presented the results to the community leaders. And I was convinced that when I showed them this data, they were going to say, we got to do something about smoking, because smoking is off the charts, right? So I show them the chart, and I say, we need to do something about this smoking problem. And they say, nope, we don't want smoking. We want mental health. I say, no, we did mental health scans. You don't really have a mental health problem, man. You got smoking. No, I see that, but mental health. And we went back and forth and back and forth and back and forth for a while. When it occurred to me that what they were trying to say to me was, and first I'm going to say it in researchese, then I'm going to say it in normal English, right? What they were saying to me is that the screens you did for depression and anxiety and all of that stuff is not picking up those conditions because we have subclinical psychological distress. And they didn't have that vocabulary. And finally, as we talked it through, we spent the time to understand each other. That's what they were saying. In other words, people are stressed out. And because they're stressed out, they're smoking cigarettes and they're drinking and they're engaging in the 3 big S's. You know what they are? Sugar, salt, and sex. The 3 things that we can use to deal with stress. Sugar, which alcohol is primarily sugar. Salt, I don't have to tell you about salt, right? Fried this and fried that. And the sex, the unsafe sex that also leads to disease as well, right? And this is what they were trying to say to me, but they didn't have the vocabulary. So it took time for us to understand each other and to have that kind of rapport and understanding that we could start to communicate with each other. And then then they had to also understand that they could talk to me plainly like that. Now, I'm often asked, how is it that you were able to get 42% of the adults to participate in this study? Didn't you have trust issues? Everybody knows African Americans don't participate in studies, right? Well, first let me say that in my entire career, I have never had African Americans refuse to be in studies more than whites. I've never had that. So I've never had a higher refusal rate for African Americans than whites. So I think that's a myth that African Americans don't want to be in studies. They are just as likely to be in one or not be in one as anybody else. It's really all about developing a rapport and trust. So you're sitting across the room from somebody and you say, you know, you want to get into this study where we're going to give you this pill, this experimental pill? Your answer is going to be dictated by who is asking me, do I trust this person, do I believe that this person is really trying to help me, or do I believe this person is just trying to find out the results of a study? So I have never had that problem, and I think that if you have that kind of relationship with the community, you're not going to have that problem. So we used, I know that you guys stress CBPR here. We use what I call a modified CBPR process in doing this study. So it turns out in this neighborhood, it was a neighborhood where I worked. I took a leave of absence a few years back and worked at a hospital in that neighborhood. And I came to know a lot of the community leaders in that neighborhood. And my project director actually lived in the neighborhood. Now, I didn't hire him because he lived in the neighborhood. He was already working on my team as a project director when we decided to do that study. And it just happened that he lived in the neighborhood. It was not intentional. But because we both had such close ties with people in that neighborhood, we knew the players. And this was what we decided. We said, okay, so we know if we go to Pastor such and such, he's going to say, you don't need a health study, the problem is prostitution. We got to do something about those prostitutes. If we went to such and such, they'd say, the problem is that these houses are a tinderbox. This is all about fire and hazards like that. Went to somebody else, they would say, no, the problem here is drugs, and on and on and on. And so we said, okay, here's what we're going to do. We're going to go into the community, we're going to do this data collection, we're going to come back with the data, and then we're going to present it, we're going to get everybody in a room, because most people couldn't get all these people in one room together because they didn't get along necessarily, but they all had relations with us. So we're going to get them all in a room together. We're going to say, now, this is what we found. Now, we got to find solutions to these problems, and we're going to see if we can get them on board. Now that was risky. I don't advise every researcher to do it that way. I think most researchers should go into the community first. We did it that way because John was a member of the community and very active, involved in the community, and in his own right, a community leader, and because I knew all of these players, and we decided that that would be a strategy we would try. Now, this is the kind of buy-in that we got. First, we were going to get space to do the study from the Volunteers of America, the VOA that was in there, and then something happened, that space was not available, and they wasn't able to allow us to do that. We went to one of the churches nearby, and the pastor hands us a key to the church and says, you can use the church as the staging area for your study. He said, as long as you're not in here on Wednesday night or Sunday, you can come and go as you please, just make sure you lock up. Gave us the key and trusted us to walk out of his building with the key to his church, and then would not allow us to pay him rent. Wouldn't take it. So at the end of the study, I actually snuck up behind him and stuffed the check in his pocket and ran away and made him take it. But he would not, he was refused to allow us to pay rent because he trusted us. He knew that we were trying to do something that was going to be helpful to the community, and he got behind us. We went back to the community with our smoking idea, and the community had completely different ideas. So we went into mental health interventions. They wanted to do stuff on nutrition. They wanted to do community cleanups. But I would say that the most impactful thing that we did is that we didn't do what I call drive-by research. We didn't just parachute in, collect data, and disappear. We had a prior relationship with the community, and we have a continuing relationship with the community, because one of the things that we did was we worked with community residents to create an organization called the Faith Center for Community Health and Wellness, which is a nonprofit now that continues the community health work in that neighborhood, and we continue to help provide them with support like evaluations for their programs, grant writing. Another thing that we did was that, so we went in and we got all the addresses of where people lived in the neighborhood, and after the study, we wrote a report on what we found. And we mailed that report to every address in that neighborhood. So whether you were in the study or not, if you refused or not, we mailed a report to every address that where there was someone living. So we tried to provide that information to give it back to people. We've given out hundreds of copies of that report to the community-based organizations there, who now have very detailed data about their community, so that when they write their grants, they can talk about their community in more depth than most people can do. And again, I think that the biggest impact we had was the fact that we were able to help create that nonprofit that's still there doing that work, and we still continue to work with them. So it's really about creating a partnership, building that trust, and maintaining a relationship, not just kind of creating the nonprofit and disappearing would be, not quite as bad as drive-by research, but it would not be that different than doing drive-by research. So the reason, though, that we need communities is because of that conversation I told you about the subclinical psychological distress. That conversation and understanding how important that was, and also understanding that health disparities are really part and parcel of 4 big disparities that we have in our community. And if we don't realize that these all 4 work together to produce these health outcomes, we're not going to find a solution. That we know that education is one of the largest, greatest predictors of health outcomes, and we also know that children being sick is one of the reasons that they're not able to develop educationally. We know that the rates of illiteracy are extremely high in prison. We also know that people who have wealth are able to afford legal services that keeps them out of prison. And the best way I can think of to keep people from developing wealth is to have them in prison between the ages of 17 and 34, which is when most people develop the human capital necessary to create wealth. The health and wealth relationship is well known. And we know that there are people who wind up incarcerated because of untreated and undiagnosed mental health problems. And that people often come out of prison sicker than they were when they went into prison. Now, none of that should be a surprise to any of you, but do we think about it in that way? Do we think of health as being part of this whole spider web of interrelated social factors? Basically, the society produces inequality. By the way, I'm going to end on this last note here. How many of you are aware that there are more black men in prison than there is in college? Okay, most of you, right? Any of you bothered to look that up to see if that was true? All right, well, I did, and I got to close with this statement. So, in 2006, there were 836,800 black men in prison. Now, nothing that I say you should interpret to mean that I think that that is an acceptable number. That is not acceptable. But in that year, there were 896,000 black men in college. Now, the college-age population is basically going to be between, 18 and 23, 24, right? Whereas the prison adult population can go up to over 100 if they can live that long in prison, right? So we were able to get the data for just the ages of 20 to 29. 310,000 black men in prison that year, 480,000 black men in college. So we then went on and said, okay, was it ever true that there were more black men in prison? So we pulled the data. This data comes from the US Department of Education and the US Department of Justice. So I don't know where to get more official data than that. And in fact, we went back to 1980 and we could not find a single year where there were more black men in prison than in college. It simply is not true. Never, now that deserves a big round of applause in that. It is not true. Now I'm going to say it's a shame that we got to applaud something like that. But not only is it not true that there were more black men in prison, it never was true. It was a lie when it was first stated, and it still is a lie. So if you get nothing else out of the time you spent listening to me this morning, nothing else, please join me in my crusade to dispel this terrible lie that's been perpetrated about black men. And I thank you. And I thank you for your time.